So let's get down to some fractures, which is the fun stuff. So many pictures and X-rays here. If I start at the hands, going up upper airway, and then we go into the lower limbs. I mean the upper limbs, going to the lower limbs, and later on, start at the tip of the fingers. Your distal and middle phalanges, usually it's enough to body strap them and splint them. You're obviously not going to put a POP over them, and they heal quickly, 3 to 4 weeks. So if they're severely deformed or misplaced, then you can do a ring block easily, reduce them, and then strap them yet again. Interesting point to avoid leaving the pinky on its own in active sports. They say that basketball players, you always strap like this, these two fingers, because in basketball, if this one is kept separate, they can actually rip off while they're playing. So yeah, body strapping is done in this pattern. Proximal phalanges is a bit more important to reduce and a bit more difficult to immobilize. Remember the principle of one joint above, one joint below when we immobilize a broken bone. So in the proximal phalanges, we will mostly reduce it and then splint it in whatever way. In the picture, on the slides, there's a nice picture of which look like an OT that's gone wild. Did a really nice job there using anything to just splint it in that position. 30 degrees at the wrist, 90 degrees at the MPJs, the metacarpophalangeal joint. So you can use, if it's the fifth finger, you can use, or fourth even, you can put a gutter splint with like a back slab over that side, basically just immobilize. Yet again, reduce and immobilize. Just two examples of interesting fractures in the hand. You might notice there and there. So this is called a boxer's fracture. It's very common. We see it on Monday mornings when they come after drinking on the weekend. So they hit a friend or a wall and you break the fifth metacarpal, distal metacarpal, and then it bend over. So that we need to reduce and then splint. This is another interesting fracture in the hand, probably more important to reduce. Well, it's called it's a proximal metacarpal fracture of the thumb. It's very important that this be reduced well. In the McGray, there's a beautiful demonstration or a picture of how to reduce it. But usually, I think in hospitals, level 2 and 3 hospitals, where the orthopedic departments is clued up, they will usually operate this because it's so important. Otherwise, you're going to sit with osteoarthritis there and big problems soon after. Then, if we look at the metacarpals, what is the normal angles we can accept in these fractures? This is a very nice slide, and actually, it's straight from the McRae. I use it a lot because I tend to not be able to remember what angles is acceptable. And this picture is an all-in-one for the metacarpals. In the basic principle is when there's a metacarpal fracture, you can accept 10 degrees on either your lateral, AP or lateral, except if it's on the distal metacarpal, then you can go up to 20 degrees, except if you're the fifth metacarpal, the pinky, you can accept, that's in other words a boxer fracture, you can accept up to 45 degrees before you have to reduce. And then number 4 and 5 in the slides, you can, just important, they must be at least 50% of bony overlap, and there must be no rotation on the fracture line. And if you can remember that, then you can look at an X-ray and decide I can accept it, or maybe I should go for a reduction. So this is, I think, a very handy slide. Then we move to the good old Colles fracture, described by Abram Colles in 1773, or he was born at that time. So it's been well known and around for many years. It's the most common fracture we see in adults, and it's especially in older ladies where the bone is more osteopenic. And it's also called the dinner fork fracture for the obvious reason that the arm is actually shaped like that once you break it in a Colles fracture. Quick reminder that the Smith and the Colles are birds of similar feathers, but just the opposite way. So in a Colles fracture, you get the upwards movement of the distal fragment. In the Smith fracture, downwards. We see the Smiths more commonly in young adults and children, because they tend to be more active and fall in funny ways. So I guess it's that reason. But you will do, just when you do a reduction for Smiths, you do the opposite what you do in a Colles fracture. So in a Colles, it's so common. It's probably the most common close reduction we have to do in our hospitals. So I think if you understand what breaks and how it breaks, then you understand how to reduce it. So it's a fracture of the distal radius. It's usually in the last 2.5 centimeters. And there's a couple of things that happen. In the picture on the right, that's now probably behind the faces of the people attending. But you'll see it if you download the PowerPoint. Then there's impaction that happens, and there's dorsal displacement and a dorsal tilt. Usually that happens with lateral displacement and lateral tilt, and supination of the whole distal fragment of the Colles. In other words, that little cup you see of the distal radius on the lateral X-ray starts looking upwards compared to looking on the normal 11-degree planted tilt that you expect. Looking downwards, it starts looking upwards. I'll show you that now. So if you do a close reduction, you're first going to disimpact and then reduce it. So I'm going to try and just quickly stop share here and demonstrate with my son in the background. So I hope everybody can see this. But when I reduce a Colles fracture, obviously I get a friend to start pull from that side, but I pull straight out of the thumb, and I give a good long pull like that. The thumb pulls straight out of the radius. So I do good long pull to disimpact, and you can use a lot of force. Sometimes if it's severely impacted, you have to actually make it worse, and then after you've disimpacted, you basically pull it over. So I do it this way, with somebody pulling on that side. After a good long pull, I put my thumb on the distal radius and I break it back into place. So when you pop it, then obviously the wrist must stay in flexion with ulnar deviation. I'll have a demonstration of that. And that's also the way I then ask people to drop the hand, to hold their hands while I put on the POP. So they can hold it, and then I can start putting on the POP while the hand is in the correct position. Right, let's share again. Good, so disimpaction, traction, and then volar flexion with ulnar deviation. So that is, the ulnar deviation is very important, because one of the things that always break with a Colles fracture is your ulnar styloid. And if the styloid doesn't break, in other words, the ulnar styloid fracture you will see on the X-ray, but if that doesn't break, then you rip through the fibrocartilage, the triangular fibrocartilage that's also situated there. And it's going to be disrupted. You need to put that back. And if you can just imagine, if you get it into ulnar deviation, then you close that space, and the ligaments and the whatever breaks there, if it's an ulnar styloid or the ligaments, it's going to be able to heal much more effectively. So what's important in this picture is just, the picture on the POP on the left is the flexion you want to see when you, or the ulnar deviation you want to see in the POP for a Colles fracture. You don't want it straight like number one. And then also some flexion, not the flexion you've seen too. So not like this, it's just some flexion with ulnar deviation. So that's how we pop it. And a forearm POP, it doesn't have to be above elbow, so it can just be a forearm. So this slide I love because it demonstrates the common mistakes we make in putting on the POP for Colles fracture or any forearm fracture. So all the way on the left is the correct position. Number one shows us how we can override onto the pinky, and then we kind of like splint it there and it can't quite flex. It's got to be able to get to 90 degrees in the MPJ. So number two, you actually override all four fingers there, and you can't get it down. So it's going to be, stand like that. You've got to be able to get to 90 degrees. And to do that, you've got to stop your POP, what seemed to be very early, but as demonstrated there in your palmar crease. Number 3 and 4 demonstrates how you can actually impinge on the thumb. The thumb's got to be able to move a lot because, yeah, abduction, flexion, adduction, it's very important. Otherwise, it becomes very stiff. And then number 5 just lastly demonstrates how we tend to make our POPs too short. It's got to go all the way to our elbows. Right, so just 1 or 2 X-rays to demonstrate, because the collis fracture is so common, I think it's worth knowing this. So this is the little cup I spoke of. If you look on the lateral X-ray of the radius. And we can accept, actually, if you draw a line through the tips of the cup, up to 10 degrees posterior tilt, according to the book. I was actually taught 90 degrees, in other words, straight up. Remember, usually it looks like that. Okay, it's behind the names, but usually you've got your 11-degree plantar tilt this way. Now, in a collis fracture, it starts looking up 10 degrees. So if you look at this X-ray and you decide, do I have to do a close reduction here? Yes, I need to, because it's too far, you know, it's tilting back. I need to just get that angle. I guess the question is to ask yourself, if I don't do this, what is the problem for the patient in the future? It's going to heal like this, and with that angle, you're going to get limited flexion. You know, you're not going to be able to basically bend your wrist very well, and osteoarthritis is going to be, in the next couple of years, a big problem for this patient. So reduction is worth it. Looking at 1 or 2 more X-rays, this one is a very nice demonstration there of, firstly, you can see there the ulnar styloid fracture. Then there is clear impaction with the resulting shortening of the radius there. So the impaction is so severe that the ulnar is actually sitting, I mean, the radius is shortening. And then if you look at the third X-ray, you can see there's the dorsal tilt is severe with 30 degrees. So the cup of the radius on the lateral X-ray is actually looking upwards. So this patient, you've got to take, they've got to do a reduction. And remember, first a big pull, long, you can pull for a minute straight out of the thumb, disimpact that fracture, and then you bring it over. Good. So, sorry, resolution on this picture is very poor. But in principle, do you want to do a reduction for this one? Yes or no? So I don't want everybody to respond. But basically, if you draw the line, and this is just to demonstrate what I'm trying to say, on the lateral X-ray, when you see that cup, normally it's got the 11 degrees forward plantar tilt. This one is up to 90 degrees. So this is actually acceptable. But you could reason that there's quite a bit of impaction here, and the patient will probably benefit from a reduction and disimpaction there. Here's another X-ray, AP in a lateral of a fracture. If you look on the top one, if you draw the line through the cups, it's probably good position. It's close to 90 degrees. So in that sense, it's probably acceptable. But if you look at the bottom picture, you can see there's actually a lot of shortening and impaction there. And this patient will most definitely benefit if the patient gets a good pull to just disimpact and then put a little bit of flexion on it. It will be much better for the patient. So yeah, there's 2 arrows to indicate. This is what I said about a hematoma block. I actually only learned this recently. I had a patient one night, and it was late at night, and I was a little bit lazy to pull out my brachial block, and I thought, like, he just broke his arm. I could clearly see the hematoma, and I thought, like, let's try hematoma block. I pulled up my 15 milliliters of 1% lignocaine, and remember, this is the lignocaine you will use to infiltrate the skin to put in sutures. This local lignocaine, and then you go straight into the hematoma after cleaning obviously very well, aseptic technique, and I injected it, and it worked absolutely perfectly. It was a young male, and he didn't complain of pain, which is quite rare. So I actually loved doing a hematoma block, and I just realized in very recent fractures, if it broke in the last 12 hours, there's usually still the whole swelling of the hematoma that formed, and then it's very easy doing this block. It doesn't seem to work for myself. later on. So if it's a couple of days old, I usually go for Bracco block or another technique. But just to know, yeah, I can really suggest trying this. Let's look at radio-ulnar fractures. So what fracture is this? Rhetorical question. I'll tell you. It's a Galeazzi fracture. And a Galeazzi, remember, you'll probably remember from varsity, is a radial fracture, usually in the distal half, with radio-ulnar joint dislocation. And then there's obviously usually overriding then of the two ends of the radius with shortening of the radius. This need a ORIF. This is the one that's worth fighting for with the orthopedic department to accept. So these are two examples of Galeazzi fractures. So you can see there the radius fracture with the distal, the radio-ulnar joint dislocation. This one, I'll give you a second to think. So it's a Montigia fracture. You probably remember that, which is a proximal half of the ulnar fracture, and they usually then the radius pops out. So they also need to get an ORIF, but I usually just try and put the radius back before I refer the patient. So Montigia fracture. Then general principle for radio-ulnar fractures, Galeazzi, Montigia fractures needs ORIF. So they need to, it's worth discussing with your orthopedic department. But then to remember, probably the most common one we see is the defensive fracture. Patients stopping someone, hitting them, and then they break usually the distal half of the ulnar. So those fractures are very stable because the whole radius is still intact and splinting the ulnar, and you can actually accept severe displacement. Like the middle picture actually demonstrates it very well. This patient, you can just put on a forearm POP, they'll heal. It doesn't need an ORIF. So isolate the ulnar fractures, which is usually defensive fractures in South Africa, we can treat mostly conservatively. So in kids, radio-ulnar fractures, how much angulation we can accept. Oh, in kids, I must just say, obviously we get more green stick fractures. The bones are more likely to bend and not shatter or break as in adults, and the periosteum, like in this first picture, is still intact on the one side, which keeps the ends together. So how much angulation, when do we have to go and do a close reduction, usually on the ketamine? And that's 10 degrees on the AP or the lateral. If the bone is displaced or angulated more than 10 degrees, we should probably go and just give it a little push. But a very important point in kids is the elasticity of intact periosteum. So I think the picture on the left demonstrates it very nicely in that we tend to go and break it back and get it perfectly straight into place. But what a lot of orthopods do, they overbreak it to break the periosteum on the other side and then center it nicely, do the POP. Because what we tend to do is we reduce it to a perfect position, we put on a circular POP, and then the swelling goes down and the elasticity slowly displaces and it angulates again. So what we need to do in our practicals, in our hospitals, is reduce it, even if you don't break the opposite periosteum, reduce it, but then you splint it nicely with a 3-point pressure. And the way to do that is, if I can just demonstrate here, is with this kind of, you mold it on the bottom where the red arrow is on the screen, and then with your hand there and there. So there you've got your 3 points, and there in the bottom. I hope that was visible in my attempt at the demonstration. So 3-point pressure in kids in POPs is very important. Good. So let's look at elbow dislocations. Elbow dislocations is usually in adults. Kids tend to rather break their